This presentation is titled The Culture of Graduate Medical Education and is designed to give you a better understanding on what graduate medical education is all about. Upon completion of this presentation, the learner will be able to demonstrate the following. Recognize the differences related to training for medical students, residents, and fellows. Identify the role of the Accreditation Council for Graduate Medical Education, the NEXT accreditation system, and the Clinical Learning Environment Review. And finally, recognize the unique culture of physician education as it relates to graduate medical education. It's important to start with a little walk down memory lane to remember where the cultural perceptions of residents got started in the media. A popular TV show of the 70s called Dr. Marcus Welby, MD, was one of the first shows that introduced us to the adored family doctor and his resident intern. The concept of a resident in training under the mentorship of a seasoned physician was brought to life on TV. What we see today is a variety of TV shows that depict residents in a variety of ways. The public moves from the Marcus Welby, MD image to the Dr. McDreamy heartthrob. And we can't ignore reality television. Life as a resident and fellow is now captured in real time with these popular reality shows. But with any reality show, the public only sees what producers want us to see in these live, real-time snapshots into the world of a resident or fellow. Taking a look at the culture of graduate medical education as it's shaped by TV pop culture can be entertaining, but let's now take a look at how the culture of academic medicine is shaping graduate medical education. The administrative structure of the medical school system looks something like this. It's not too different from any college campus, but the uniqueness of GME includes specific residency program directors that are responsible for the administration of the actual residency training program and for assuring compliance with accreditation requirements. At EVMS, Dr. Homan is our president, provost, and dean. Before we can really dive into the specific culture of graduate medical education, we first need to start sequentially by explaining the medical education progression of physicians in the United States. It's going to look something like this. The first 4 years are going to be the undergraduate degree, then 4 years of medical school, then another 3 to 4 years of residency, and finally, a fellowship if you choose. Here's a quick snapshot of the undergraduate focus. Typically, it's going to be science-focused majors. However, you can follow other and different pursuits for medical school. You must take core classes for medical school acceptance in addition to your undergraduate requirements. You need to be involved in extracurricular activities. You need to pass the MCATs and make sure to complete the application process. There are 2 types of undergraduate medical education training programs for physicians. 1, allopathic, and 2, osteopathic. So you might ask, what is the difference in becoming a DO versus an MD? Well, let's take a look. The DO is a doctor of osteopathic medicine, and the MD is a doctor of medicine. The traditional medical degree, the MD, requires training in allopathic medicine. Osteopathic medical schools award the DO degree. Both attend medical school and receive substantial training, 4 years, not including the residencies. The curricula for both schools are similar. State licensing agencies and most hospitals and residency programs recognize the degrees as equivalent. Osteopathic doctors are legally and professionally equivalent to allopathic doctors. Osteopathic medical schools take a holistic perspective on practice of medicine based on a relief in treating the whole patient, mind, body, and spirit, and the primacy of the musculoskeletal system in human health and the utility of osteopathic manipulative treatment. DOs emphasize prevention, a historical distinction which is less relevant as all of medicine increasingly emphasizes prevention. Allopathic medical school looks something like this. Year 1 is your basic physiology and anatomy. Year 2, pathology and diseases. Year 3, your core clerkships. And Year 4, specialized clerkships, residency applications, and interviews. Osteopathic medical schools are typically similar to MD programs, but include 200 additional hours of training in the art of osteopathic manipulative medicine. This system of hands-on techniques helps alleviate pain, restores motion, supports the body's natural functions, and influences the body's structure to help it function more efficiently. Now that you have a basic understanding of medical school progression, it's time to look at the next phase of physician training, which is graduate medical education. Residency education is the period of clinical education in a medical specialty that follows graduation from medical school and prepares physicians for the independent practice of medicine. The term postgraduate year, abbreviated as PGY, reflects the number of years the resident has graduated from medical school. For example, a PGY-1 indicates the physician is in their first year of training after medical school. This year is also referred to as their intern year. Sometimes the term intern gets confused with being a medical student. So for clarification, interns have graduated from medical school and they are a physician. Let's move on now and talk a little bit about fellowship training. A fellow is an MD or DO who has finished residency. However, they are now pursuing additional subspecialty training. A few examples might be internal medicine goes on to study cardiology or endocrinology. General surgery might go into vascular, pediatrics. Different fellowships have varying lengths of training. So far, we have explained medical school training and the general progression of training for resident physicians and fellows. We are now going to spend the remainder of time focusing on the essential components of graduate medical education. We can't talk about graduate medical education without addressing the ACGME. The Accreditation Council for Graduate Medical Education is a private, nonprofit professional organization responsible for the accreditation of 9,600 residency and fellowship education programs. The ACGME's volume of accredited programs makes it one of the largest private accrediting agencies in the country, if not the world. The designated institutional official, also known as the DIO, has the authority and responsibility for the oversight and administration of the ACGME accredited programs and is responsible for assuring compliance with ACGME institutional requirements. The DIO at EVMS is Dr. Linda Archer. She is a nationally recognized DIO by the ACGME and was the recipient for the Courage to Lead Award in 2008. The ACGME was established in 1981 from a consensus in the academic medical community for an independent accrediting organization. Its forerunner was the Liaison Committee for Graduate Medical Education, which was established in 1972. The mission of the ACGME is to improve healthcare and population health by assessing and advancing the quality of resident physicians' education through accreditation. The ACGME's Chief Executive Officer is Dr. Thomas Naska. In academic year 2013-14, there were approximately 9,600 ACGME accredited residency and fellowship programs. There were 130 specialties and subspecialties with approximately 700 sponsoring institutions. The number of active full-time and part-time residents and fellows was over 120,000. The ACGME has 28 review committees and 1 recognition committee. Each review committee comprises about 8 to 20 volunteer physicians. Members of the specialty review committees are appointed by the AMA Council on Medical Education and the applicable American Board of Medical Specialties member board, as well as other applicable specialty organizations. Members of the Review Committee for Osteopathic Neuromusculoskeletal Medicine and the Osteopathic Principles Committee are appointed by the ACGME and the American Osteopathic Association. Members of the Institutional Review Committee and Transitional Year Committee are appointed by the ACGME Executive Committee and confirmed by the Board of Directors. The ACGME's member organizations are the American Board of Medical Specialties, American Hospital Association, American Medical Association, Association of American Medical Colleges, the Council of Medical Specialty Societies, the American Osteopathic Association, and the American Association of Colleges of Osteopathic Medicine. Member organizations each nominate 4 members to the Board of Directors, which also includes 2 resident members, the chair of the Council of Review Committee residents, and a resident member appointed by the Resident and Fellow section of the American Medical Association, 3 public directors, the chair of the Council of Review Committee chairs, 1 to 4 at-large directors, and a non-voting federal representative. To give you an idea of what EVMS's ACGME accredited programs look like, we have 30 ACGME programs, 18 residencies, which have 308 residents, and 12 fellowships, which have approximately 25 fellows. In 1999, the ACGME revolutionized the education of residents and fellows through the introduction of requirements across all specialties related to 6 content areas which were termed general competencies. The 6 competencies are medical knowledge, patient care, professionalism, interpersonal and communication, systems-based practice, and practice-based learning and improvement. Regardless of specialty, all programs were required to develop educational content and evaluation systems to assess the acquisition of skills in all 6 competencies. 10 years later, ACGME began a multi-year process of restricting the accreditation system, which was to be based on assessing the outcomes of the educational processes. Termed the Next Accreditation System, or NASS, this once again pushed the residency and fellowship programs towards a more structured and standardized system of education. In addition to assessment of outcomes, the NASS also expanded the content areas of patient safety and quality improvement through the introduction of a review process titled the Clinical Learning Environment Review, or CLEAR. Another aspect of the NASS included an emphasis on faculty development related to teaching and assessment. The NASS also required enhanced oversight by the sponsoring institution and expanded the accredited cycles to 10 years for accredited programs, with added ACGME annual review data entered by the programs into the ACGME accreditation data system. While not in and of itself an accreditation site visit, the CLEAR site visits are required for all sponsoring institutions of ACGME accredited programs. The only requirement is that a site visit must be conducted. The site visits focus on understanding the degree to which the resident and fellows are integrated into the hospital's patient safety quality improvement programs and the degree to which hospital leadership understands and is invested in the residency educational programs. As with other elements of NASS, CLEAR has a focus on documentation of outcomes of educational interventions. In this presentation, we shared the media's impact on how the public conceptualizes residents, the medical school training for an MD and a DO, the components of residency and fellowship training, and the role of the ACGME, NASS, and CLEAR. The culture of graduate medical education is truly an exciting and significant element in the longitudinal educational and professional development of a physician in the United States. As the ACGME evolves, this will continue to shape how residents and fellows are trained in this country. We hope you found this presentation helpful in general understanding the culture of graduate medical education.